Okay, so good afternoon, everyone. I'm not presenting a country's response, but I'm presenting on behalf of the Pan-Caribbean Partnership on HIV and AIDS, PANCAP, and that's where I come from. And so my presentation really captures the entire Caribbean. So I'll give you just a quick outline because I come from PANCAP and I think that this will be beneficial for some of the non-Caribbean participants in the room. A quick outline on PANCAP and then I'll go into the other aspects of the presentation. So PANCAP, like I said, is the Pan-Caribbean Partnership Against HIV and AIDS. It was established in 2001 by CARICOM and it was signed by the heads of government of the Caribbean. It is really a regional partnership of government, regional civil society organizations, regional institutions and organizations, bilateral and multilateral agencies, and contributing donor partners. It provides a structured and unified approach to the Caribbean response to HIV, and we work with a Caribbean regional strategic framework that has 5 priority areas: the enabling environment, shared responsibility, prevention of HIV transmission, care, treatment, and support, and sustainability. And for more on PANCAP, I encourage you to visit the PANCAP website, www.pancap.org. So in terms of HIV in the Caribbean, we've heard a lot this morning, and so just very big picture, the prevalence is about 1.2%, 310,000 people at the end of 2017 living with HIV in the region. For 2017, the region reported an estimated 15,000 new infections that occurred and 10,000 AIDS-related deaths. So in terms of new infections, we've seen that from 2010 to 2017, the region has reported a decline at 18%. New infections. So at the end of 2017, the 15,000 new infections that we've reported actually represents 18% from 2010. Similarly, from 2010 to 2017, there has been a reduction in AIDS-related death of about 23%. And so while we take all of that into consideration, the UN AIDS report of 2017 made the note that there has been moderate progress in prevention and treatment in the Caribbean. I'm sorry, this is a repeat of that same slide. Just to say that while there's been a reduction in new infections, so we've had 15,000 new infections in 2017, that we also know that the new infections are coming from very specific groups. So for example, the group of men who have sex with men and commercial sex workers account for the majority of the infection with the rest of the population and clients of sex workers. We also know that more than 80% of new infections occurred in 4 countries in the region, and that is Haiti, Dominican Republic, Cuba, and Jamaica. Similarly, in terms of AIDS-related death, more than 80% of the AIDS-related death occurred in 3 countries: Haiti, Dominican Republic, and in Jamaica. In terms of the HIV treatment cascade at the end of 2017, we can see that we've made progress, but we also see that that's compared to the previous 2 years. At the end of 2017, we have 73% of people living with HIV know their status. 57% of persons living with HIV are receiving antiretroviral therapy, and 40% of people living with HIV are virally suppressed. Presented slightly differently in relation to the status of 1990, we see that 73% of people living with HIV know their status. Among the 73% of persons who know their status, 79% are on antiretroviral therapy and 70% are virally suppressed. So I'll take each of the 90 and present some very specific examples. So in relation to the first 90, when are persons coming in for treatment? Now we've heard from Suriname that persons come in for treatment at a very late point when they have signs and symptoms already. We've seen that we've made progress in the region, but it still remains significantly high. So at the end of 2017, 23% of persons being diagnosed are diagnosed very late with signs and symptoms of AIDS. In terms of the second 90 again, there's been an increase in the number of persons the region has put on treatment, And we can see that at the end of 2017, there's 181,000 persons on treatment, which really is 57% of all of those persons who should be on treatment. I think that with more and more countries in the region rolling out Treat All, that we'll be able to see greater coverage for antiretroviral therapy and see an increase from the 57% that we've seen at the end of 2017. On the second 90, I think when we look at coverage for men and women, there's a difference. And when you look at the epi data, you can see that the epidemic is almost 1-to-1, male to female. But when you look at coverage for ART, we're seeing a slight difference. So there's 66% of all women living with HIV are on antiretroviral therapy, and 49% of all men living with HIV are on antiretroviral therapy. So there is that difference, and the Global AIDS Monitoring Report has actually called that out to say that we need to be looking at services for men. And slightly different in terms of the pie chart, 53% of females are receiving antiretroviral therapy as a proportion of all persons receiving antiretroviral therapy, and 44% male. So on the third 90, in terms of viral suppression, I think there are two things here. We see that for 2017, there's been a slight reduction in the average for the region. So we've started out 72.5% among all persons receiving antiretroviral therapy for 2015 and 2016, and that has slightly declined in 2017. I think another observation that we've made at PANCAP is that fewer countries have reported to the Global AIDS Monitoring Report for 2017. And so we're trying to understand why is it that less countries are reporting and not more countries. So we're exploring that situation right now. It could be that there are supply chain issues with availability of viral load testing, reagents, and so forth. And so countries are hesitant to report, but we did make an observation that fewer countries have reported to the 2017 Global AIDS Monitoring Report. In terms of viral suppression, again, here is where the UNAIDS Global AIDS Monitoring Report has actually called out the difference between males and females. We can see that in 2017, for all of the countries that have reported to the Global AIDS Monitoring Report, with the exception of Cuba, that viral suppression rates are higher in females compared to males. Having said that, where are we in the region in terms of access to viral load? And we can see the countries that are here. The OECS, the Organization of Eastern Caribbean States, have recently procured 4 gene expert machines, and those are being implemented in 4 countries. So Antigua and Barbuda, Grenada, St. Lucia, St. Kitts, and St. Vincent and the Grenadines. Currently, they're not doing viral load testing on the equipment, but it's being validated, and so the expected timeline for this to happen is actually early 2019. Now, what's important is that they will be able to do HIV viral load as well as chlamydia testing early 2019. Having said all of that, I think to wrap this up, when we look at stigma and discrimination and when we look at access to services, we know that stigma and discrimination continues to be a barrier. And so I've pulled out the example of Belize, and Belize have conducted an HIV stigma index survey, and what it showed is that close to 70% of people living with HIV were denied health services because of their status in the last 12 months, and that close to 90% of people living with HIV reported that a healthcare worker ever disclosed their HIV status without their consent. So significantly high numbers. And then 17% of people living with HIV in Belize reported that they would have avoided going to a clinic in their local areas in the past 12 months because of their HIV status. And so when we think about the 90-90-90 and we think about access to services, stigma and discrimination continues to remain a significant barrier for us in the region. I'll now move on very quickly to PrEP, and we've heard a lot from Dr. Rambaran in terms of PrEP in Barbados. But to say that in the region, there are 2 countries that provide PrEP in the public sector, and that is the Bahamas and Barbados. Bahamas started in 2015, Barbados started in 2018. There are some other countries that are providing PrEP in the private sector, and within civil society organization, but I'll speak a little bit to the experience in Barbados and the Bahamas. So Barbados really implemented their PrEP policy and guidelines starting March of 2018. And they've used the clinical guidance that was adopted from WHO and from CDC. And so Barbados, in their policy, acknowledged that PrEP for HIV prevention may be offered to any person in Barbados who is deemed to be at substantial risk for HIV. And they've outlined in their guideline what they feel are the eligibility criteria for PrEP. So one, the person has to be HIV negative. Two, there has to be no suspicion of acute HIV infection. There has to be a substantial risk for HIV infection. They made reference to the indication for the use of PrEP that Dr. Rambaran outlined in her presentation earlier this morning. There has to be no contraindications for PrEP, and there has to be a willingness to use and adhere to PrEP. So I spoke with both Dr. Anton Best from Barbados and Dr. Nikia Forbes from the Bahamas to find out some of the lessons that they have learned. And so a few things came out. One, there is a very high interest for PrEP among the key populations in the region. Secondly, I was told that it really makes sense to conduct a readiness assessment, not just to understand how ready is the population, but what are some of the facilitators and some of the barriers to access to PrEP. It helps to have a formalized PrEP policy because then you get buy-in from the highest level. And in that way, you can also have some assurances that funding and resources will be made available for this program. It's important for you to have engagement with all stakeholders. There is the need for education, and this came up in the summary discussion of what took place at the IAS in Amsterdam. That education is important, not just for healthcare workers, but for the key populations, for the public. We need to continually educate in relation to PrEP. And of course, finally, what I heard very clearly from both parties is that there is the need to have a combination approach modality to PrEP. And so it's important that you acknowledge that this is not about giving ARVs to somebody who is at high risk, but that we need to look at the individual and take the opportunity to bring on board all of the other things that we've heard about this morning. So the increased rates of other sexually transmitted infection, hepatitis C infection, and so use that as an opportunity to be really manage the person, not just for PrEP, but for all of the other issues. The final slide that I have is on HIV in the Caribbean. And this, the data I got from the World Health Organization, and so for 2017, there were a little over 200 TB. Sorry, there were about 21,000 TB cases in the region, and you can see the numbers. So there are 7 countries that have pulled out as countries with significant numbers. There are other countries in the region that had, for example, 1 case or 2 cases, particularly some of the OECS countries. But you can see that some of the larger territories had larger number of TB cases. What I've pulled out specifically from the WHO report is that we've had 212 reported MDR TB cases for 2017, which really translates to about 1% of all TB cases in the region. In fact, and I looked at the data also, what it's showing is that majority of the cases are pulmonary TB, and that extrapulmonary TB are cases that occur primarily among persons who are co-infected. Of note, in the report, in the WHO report, HIV testing coverage is over 90% for all of our countries among TB patients. And then the 2 line graphs that I wanted to touch on is the blue one really speaks the percentage of treatment coverage. So it's an estimated number of persons that you have on treatment over the estimated number of TB cases. And so when we look at that, that looks really good. But when we look at treatment success rate, which is the yellow line for the 2016 cohort, we're seeing that treatment completion is not as high as it should be. And in fact, I think our highest treatment completion was in Cuba. Haiti has good treatment completion rates for its 2016 cohorts. But when you look at some of the smaller territories like Guyana, Suriname, Belize, and Jamaica, our treatment completion rate for TB has not been that great. And this is the report for the 2016 cohort. So in summary, I think just to recap, the UNAIDS report did note that there has been moderate progress in prevention and treatment in the Caribbean, but there remain significant gaps around the 1990. Stigma and discrimination continues to be a major obstacle to access to services. Our supply chain issues continues to challenge some of our territories. I didn't touch on ARVs, but certainly for things like viral load, reagents and supplies. There is a great demand for PrEP, but I think uptake has been really slow among our countries. And finally, in terms of TB HIV, there's been a high uptake of HIV testing among TB patients. High TB HIV comorbidity, I didn't mention this, but on the slide, TB, the WHO report did make note to the fact that many of the countries that I presented had TB HIV co-infection rates of 20% and over, and I think we heard a similar story from Suriname. TB continues to be a leading cause of death in HIV patients with significant TB HIV co-epidemics. Thank you.